Hello, this is Habib Srour with Anesthesiology Critical Care here at UK. This is a quick supplement to the lecture that I do on pacemakers and ICDs, intended to give folks a primer. So some of this we talk more about in person, but we'll talk a little bit about pacers and ICDs, and hopefully it won't seem like what this slide looks like when you look at it. But this is actually an older slide that shows the variety of devices that do exist. This was actually a group that tried to make a system for you to decide what the device was based on how it looked on the chest x-ray. So I've never actually successfully used this, but with the advent of AI, this has actually been incorporated into various apps that you can use, and you can see they have whimsical names over here on the right for things like wine glass and purse. But the point is, there's a lot of devices. If you don't have a good basic understanding, I would strongly suggest you read this by Dr. Wallace. A lot of what is in this PowerPoint actually it's based on some of what he teaches in his reading. He's a biomedical engineer, I believe, anesthesiologist, and has a very good way of explaining things that are quite complex. So just starting at the basics, remember that you pace with some amount of current, usually in milliamps. You sense generally with a voltage in millivolts, and that should make sense, no pun intended, because remember what's on the y-axis on telemetry or on ECG is in millivolts. It's a threshold. And then when it comes to the letters of these devices, there's a lot of them. In fact, it's way more than 3 letters, and then there's pluses and minuses and other things that are used for these implantable devices to actually look and see if you need a higher heart rate, like if you're trying to run a marathon, for example. But the basics here are PSA, like public service announcement, pace, sense, and action. And the other way to remember this is it's a pacemaker, so the first letter is telling you about the pacing. So D stands for dual. It paces the A, atrium, and V, ventricle. It senses the A and V, and it inhibits the A and or V with any activity sensed within the sensitivity threshold, which we'll talk about, and the refractory period, which depends on basically the set rate or the AV interval on the device. A quick aside here in terms of electricity. It's good to understand electricity to some degree, especially if you deal with it in the operating room, but also in the ICU. Remember that there are 2 realms when it comes to electricity: macro shock and micro shock. And the difference between these two is the having intact skin impedance. Right, so your skin prevents a lot of the difficulty. You can see here VFib, this is the threshold, milliamps with intact skin. Microshock, you go down to microamps, so orders of magnitude different. And if you think about what we do to patients that puts them into the microshock territory, it's a huge deal. And when we do this stuff in person, we'll talk more about the maximum leakage current, etc. I always thought about, in dry air, if I rub my feet on the carpet and then shock someone, just so that you're aware here, it's about 30,000 volts and 2 milliamps. So you can see that it's way below the threshold of risk for macro shock, but it's way above the threshold of risk for micro shock. And then electrical isolation, we can talk more about in person, but just recognize that if you think about Ohm's law, V equals IR, so that's voltage is current times resistance. If you solve for current, so that I, which is what we're talking about on this slide, right, the milliamps here, if resistance is approaching 0, no matter how small V is, right, since the resistance is in the denominator, if it's approaching 0, I is approaching infinity, right? So that causes lots of danger for folks. So going back to pacers, when it comes to sensitivity, there's a lot of different ways to think about this. Some people like to use the fence analogy, where if the fence is high, you can't see through above it, et cetera, et cetera. But what I'll say is, if you look at this telemetry here, if this line here is the sensitivity threshold, and this is a V lead, then this is appropriately sensing, right? So it is seeing the QRSs, the thing you want it to see. It is not seeing the stuff you don't want it to see, so the P and the T. So what would happen here if I took this line, the threshold, and I put it way up here, right? So now it's not seeing anything. What you should start to, the framework you should start to have in your mind is that if the patient is over or under sensing, then they will do the opposite when it comes to pacing, and vice versa, right? So if a patient is over sensing, they're going to under pace. If a patient is under sensing, they're going to over pace. If you walk in and see a patient who is having inappropriate pacing spikes, they are over pacing, then one of the possible causes would be under sensing. So just get that straight in your mind. But if we put this up here, that would be what? Over under sensing. It would be under sensing. It's not seeing what it's supposed to see, which means the risk is going to be over pacing. This thing's going to fire when it's not supposed to fire, and the risk would be like an R on T. If I took this line and put it down here, so it's crossing all three of these, it's seeing three things for every one beat. That is over sensing, which means it's going to under pace. And that should make sense. If I have it set to a backup rate of 60, if it's seeing 3 beats for every 1 beat, then the patient's heart rate would have to get down to 20 before this thing would start to fire. And that's bad news bears, right? So the dreaded problems are what I just mentioned. You can have asystole or heart block if you have a patient who's pacer dependent. That means without the pacer, they don't have a perfusing rhythm. They are set to a space synchronous mode. So they're in a mode that is sensing. And something's happening that's causing oversensing, so like electrocautery. So oversensing, they're going to underpace, and you're going to get asystole or heart block. Or this R on T, like we mentioned, you have a pacer set to an undersensing mode or a not sensing mode, so blank OO. And the thing that trips people up here is the rate needs to be set lower than the intrinsic rate, and that should make intuitive sense. If the rate is set higher than the intrinsic rate, you're never going to have an intrinsic beat. It's just going to be the paced beat. But if it's lower, so the pacer is set to 60 and the patient's heart rate is 80, there's going to be a problem, right? Because the patient will have native beats, and then you can end up with an R on T. So this gentleman that I mentioned earlier has a good sense of humor. He calls the OO modes. He talks about how they're not something you leave someone on without someone with expertise at the bedside, right? 00 and 007 stands for license to kill. So make sure that you have someone at the bedside who knows what to do if a patient starts to be in danger. AICDs, they're much more complicated. So these are defibrillators, and you need to know information about these things before you take someone back, ideally to the operating room, or when you have them in the ICU, you want to know what their anti-tachy threshold is, for example. Magnets. So knowing what the magnet mode is for a particular device is worthwhile. So most AICDs, I've capitalized most because it's not all. When you put a magnet on, it disables the anti-tachy therapy. So this is like shocking and overdrive pacing, but it doesn't change the pacer programming. So if they're set to DDD at 70 and you put a magnet on, they're still on DDD at 70. And so if you go and do, let's say you take a patient with an AICD and you start to bovie, they're going to get shocked if you don't do anything. If you put a magnet on and you start to bovie and they're pacer dependent, then they will code, right? Because the pacer is going to oversense, which means it's going to underpace, right? And then with a pacemaker, if you put a magnet on, it usually puts the patient into a dysynchronous mode. So blank OO at some set rate, 90, 99, 100, something like that. So just recognize what the implications of that would be. End of life mode is a big deal. If they have less than 6 months left on the battery, then it will half the magnet mode rate to try to keep the patient alive as long as possible, etc. Why that matters is because of what we talked about in this slide here, right? If the patient's intrinsic heart rate, as it relates to the paced rate, it has different implications, right? So if the paced rate is half of what it normally would be, then there's more risk to the patient. Pacemaker-mediated tachycardia. So this, if you work in CVICU, you'll see that certain surgeons will put in A wires and some won't. And there's lots of implications to that. Like what would happen if you have a patient in DDD and they go into A flutter with an HO rate of 300? Well, the pacer, if it's sensing 300 on the A's, an older pacer would just try to fire the V's at 300. That doesn't happen anymore because now we have an atrial tracking limit, which sets it to 100 or 110, something like that. But that's where pacemaker-mediated tachycardia comes from. There are other implications here too. The A wire it's on much thinner tissue. When you pull it out, it's much more likely to bleed, et cetera, et cetera. But there are benefits to an A wire. We'll do an atrial EKG with it sometimes, which is really great. So it's basically a zoomed in view of lead 2. And you can also wrap like ludicrous, right? So it's called rapid atrial pacing, where you fire very quickly to try to take someone out of atrial flutter, for example. If a rhythm is organized enough that there is some non-refractory period, you could try to capture on it. And so that's something we talk more about in person. Bi-V pacers, you should be concerned if you see someone with a bi-V. Remember, it's dual chamber for A and V. It's bi-V when you have both Vs on there. So the patient basically is so reliant on ventricular interdependence. Remember how the heart actually contracts, the ventricles depend on each other. So if they depend on this is called cardiac resynchronization therapy. It's one of the steps before putting someone on MCS, mechanical cardiac support, like an LVAD, for example. You can determine this from the chest X-ray. We'll talk about it. You should think through where is the LV lead. It's not in the cavity of the LV, right? It's in the coronary sinus. There are lots of QRS morphologies you might see because these things happen independently. And then there are criteria you should have in your mind when it comes to this type of stuff, right? MI and left bundle, that's a huge deal because most pacers, not bi-V, but regular pacers, have a left bundle pattern. So it's hard to diagnose MI, and you need to be aware of Skarbosos criteria that it exists, really. And then Brugada criteria is differentiating between VT and SVT with aberrancy. And the simplest thing that I've found is this peak R wave progression time. We won't talk about it in this slide deck, but when we talk in person, it's something we can consider, but it might be worth something reading about if you're interested. Some films. So you can see here, this is just this is a bi-V pacer. So there's an atrial lead here, and then right ventricle and left ventricular lead. Some of these are older pictures, but you can get the idea. Here's a dual chamber with an A, and here's a V. Here's a single, just a right ventricle. And then here's an AICD. The difference with an AICD is you have this thick coil for the defibrillator coil. So that's one way that you can tell that it's an AICD. External pacers, which we use a lot on the CVICU. You can see the epicardial wires, they come out in the orientation of the heart by convention, right? So the atria are more to the patient's right, ventricles are more to the patient's left. Scarring is a real thing with this. Remember, when you constantly shock tissue, it creates scar. Scar has a higher impedance than not scar. And so if you have someone who's pacer dependent, you don't want to cause scarring unnecessarily because you'll make the pacer basically last a lot less. Its life will be shortened. And then obviously you should insulate your hands. Transvenous pacers we won't talk about. And these cases we can do more about in person. But there are some good cases to go through, and this is the pacer megacode is a real thing, and it's worthwhile to think through. So hopefully that helped a little bit and got your feet wet with this stuff. If you have any questions, feel free to text or email me anytime. Thank you for your attention.